Good afternoon or good morning to some of you joining in other time zones, and welcome to today's presentation on medical student and trainee mental health and wellness. Today's session is a collaborative conversation on fostering a healthier, more supportive environment for both medical students, graduate students, and trainees during these challenging times. Focusing on mental health and wellness, we will discuss how training programs, schools and institutions can be more mindful about providing resources and offer practical tips to faculty and to trainees on addressing their own well-being while managing other difficult issues. This webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership. The mission of the DICP is to support excellence in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence and foster innovation at a local, national, and global level. Our efforts support the career development of junior faculty, trainees, and students. We identify and train leaders in academic medicine and health policy, and we provide programs that address crucial pathway issues in addressing healthcare education and training. Before we get started, a couple housekeeping notes. Chat is not available. Microphones will be muted. Use of Q&A is encouraged, and we're going to try and make sure we engage all of you and get as many questions answered as possible. So please use that way to communicate with our panelists. The webinar is going to be recorded and will be posted on the DICP website. It'll be posted hopefully along with captions to make sure everyone is able to access this information. And so now I have the pleasure of introducing our panelists, and I'm excited to hear from these three because this is a group that was, I think, well cultivated and is going to help address many of the questions that we have. First up is Dr. Ijeoma Opara, who is a double board certified physician scientist, movement builder, and associate professor of internal medicine and pediatrics at Wayne State University School of Medicine in Detroit, Michigan. She is an NIH-funded health equity community engagement implementation officer and the founding director of the Health Equity and Justice in Medicine Initiative, co-founder and director of Wayne State University Global Urban Health and Equity Curriculum, and co-founder and chair of the Detroit in Race-Based Medicine Task Force. She is an internationally renowned award-winning educator, scholar, and leader in anti-racism and anti-oppression, decolonization, and Black liberation, and focuses on joy, abundance, and brilliance of Blackness. Thank you, Dr. Opara. Next up is Dr. David Abramson, who's a board-certified psychiatrist who serves as both the director of psychiatry at Harvard University Health Services and director of mental health at Harvard Satellite Clinic on the Longwood Medical Area campus. In his clinical and administrative capacities, he is dedicated to ensuring students have access to and receive the highest quality psychiatric care during what can be immensely stressful time during their lives. And last but not least is Dr. Paolo Lozano, who is an assistant professor of psychiatry at Harvard Medical School and director of the Division of Translational Neuroscience at Beth Israel Deaconess Medical Center. He specializes in diagnosing and treating psychotic disorders, particularly during the early stages. He leads a multidisciplinary team providing comprehensive care that integrates psychiatric evaluation, psychological services, and neuromodulation therapies. He's received significant funding from the NIH and the Burroughs Wellcome Fund and has authored over 80 publications. Dr. Lozano's integrated approach to clinical care and research continues to advance the field of neuropsychiatry, particularly in the early detection of prognostication, intervention, and psychotic disorders. So thank you to our panelists. Looking forward to hearing from you. My first question is going to go to you, Dr. Abramson, and Sabrina, if you don't mind taking down the slides. Thank you. So David, I really would like you to just shape the scope for us as we have this discussion, bringing it to the medical students. What's the big picture? Can you tell us what are the issues that you're seeing with students when it comes to mental health?
Yeah. So, I mean, broadly speaking, a lot of the themes are the same as they ever were, meaning people come in for adjustment problems, depression, anxiety, trauma history, sleep issues. So in some ways, the more things change, the more they stay the same. I mean, that's the common kind of presentation. At the same time, there really are a lot of differences that have kind of either evolved or taken off over the last 5 to 10 years. So for instance, there's much higher rates of general distress in the student population. And distress is defined as, depressed mood, anxious feelings, hopelessness, and frankly, sometimes increased rates of thoughts about suicide. And that dates even pre-pandemic. I mean, the pandemic and all that came with it certainly contributed, but this was happening 10 years ago, or the increases were happening 10 years ago. Doesn't necessarily mean there are more people with diagnosed mental health disorders, and that's maybe an important difference, but there's definitely a lot more distress out there. One of the ways that we're really seeing a lot of that manifest recently, sometimes and has to do with particular cultural, societal situations or events, is anxious avoidance, where people are kind of frozen or just avoiding things. They can't deal with it, or they zone out, they kind of doom scroll, they're on social media. And it shows up in my office and it shows up in the medical school, where people, well, quite the opposite, they don't show up. They're not coming to class. They have a hard time getting out of their room. They're isolated. And sometimes in an even more worrisome way, they're not responsive. They're not communicating with friends. They're not responding to emails. When people reach out expressing concern, they don't reply, and that amplifies some of the concern because people don't know what to make. And I think that's also translated into an increased role of the teaching faculty having more of a role in the mental health lives of their students. And I think I've noticed sort of a bidirectional kind of pattern there, where students are much more comfortable texting and just reaching out that way, and that kind of pulls in other people to respond by text. And they have kind of more of a relationship with advisors that are, just online or just texting and calling. And it puts the teaching faculty in maybe in an uncomfortable, or at least a new position, where they're hearing things about their students' lives that they may not have been hearing about before. There's an increased familiarity with everything that they're going through. We also see a lot more students coming in, into the mental health office, having self-diagnosed. They have come in saying, I've been watching some TikTok videos, or my Instagram feed is telling me that I have ADHD, or I think I might be on the autism spectrum. And a lot more people have come to that conclusion on their own, and they come in maybe in distress, but they have a very concrete idea of what the cause of that distress is, and they're waiting for their provider in the mental health field to verify that or validate that. And with all that's going on in the world, it's become a lot more difficult to kind of find that dividing line between what is a normal reaction to a very unusual situation or a very intense stress and what truly is a mental health disorder. And we want to be careful not to skew too far in either direction, either over pathologizing a normal reaction or over normalizing something that's really problematic and could be a reason for concern. And some of these things have always been true in mental health care, but they're much more true these days. And not to take things too far in a political direction, but with all that's going on politically, there are people who are very anxious, and reasonably so, related to, immigration policy, economic policy. And it's an interesting kind of challenge in the conversation with students when they come in to say, well, yes, you're in distress, but I don't want to make this sound like it's your disorder. It's not like you have a problem. This is a real reaction to something going on in the world. And at the same time, don't want to be dismissive of the distress just because there's a source to it. So I think I'm having a lot more conversations with people about how do you still manage and cope with what's going on when it's manifesting as what would otherwise be considered conventional psychiatric symptoms, and yet there's a very rational reason why you feel that way. And sort of the final intersecting point with that is, students are coming in with much more of a vocabulary about their identity and how they define that, how they present in the world, what it means to them, how the world sees them. And a lot of the work that we're doing as we're getting to know people is trying to figure out, well, what are the important aspects of their identity that are just important to know about because that's crucial to who they are? And are those things the reasons why they're coming to talk to us? They may not be. So, we have to walk that fine line of saying, or is an important aspect of your identity, and I'm glad you're sharing that with me. But I don't want to make that the focus of what we talk about unless that's what you want to be talking about. And, how does that impact, just the relationship that we have with people? Because we see people from all over the world, very different backgrounds, and we never know when somebody comes in, is that how much of that is what's bringing them to our office, or how much of it is, just an important part of their life that not related to mental health. So a lot of these things are very different than maybe they were 5 or 10 years ago. So we've seen a lot of changes.
Thank you for that sort of overview. I think it's important for us to think about normalizing the abnormal because there's a component of what's happening in our country that is very abnormal and very atypical. I think there's also a component that you mentioned that I want to highlight, which is the generational differences in how we communicate versus others in this younger generation. And then lastly, many of us are physicians and have at least the medical school exposure to psychiatry and mental health, or some have more of an involvement with their training, and we have to balance that role as educator versus trying not to diagnose and treat our students. And I think it's an interesting space for a lot of us to be in. And so those are all questions that we may get back to later on. But I want to go to another question where I think is really important is one issue that happens with us in medicine is that there is stigma both with the diagnosis and with treatment of mental health conditions. Can you talk about stigma in medicine? And just to sort of put this into perspective, I was having a conversation with my colleagues and we have to fill out these peer evaluations. And they always ask about, do you know about a mental health issue with your colleague? And we're talking about this with students, but I think it sort of can be brought to a bigger level with all of us in the healthcare setting.
Yeah, no, I think in a very positive way, the conventional external stigma has decreased recently, where students are much more comfortable talking with each other and disclosing mental health concerns and the fact that they even seek mental health care. It's very different than it was 5 or 10 years ago. But there are still a lot of like concerns, either practical, like, maybe part of what you're alluding to is they worry about, well, I don't care if my friends know I'm seeing a therapist, but what about my advisor? Or what if the school finds out? Or what am I going to have to put on my licensing application? There's a lot of sort of old things that have just carried forward where mental health is something that you have to disclose. And people don't know quite what to do about that. Um, and I think there's also an internalized stigma that people still carry, even if those around them don't judge them, they judge themselves. So there's a lot of feeling of like, I should be more resilient, or I have to keep my eyes on the prize. I can't let myself take a break to take care of myself, even if everybody else is telling them, take a break, slow down. Um, or that the idea of seeking treatment involves some sort of weakness or failure on their part. And that's very much internalized. Sometimes it comes from people in their family culture, their background, their religion. They've heard that message from other people, even if they can sort of distance themselves from it. And they say, I know I shouldn't think that way, but I still hear that. I can't unknow that, or I can't unhear what I've been told, or I don't want to lie to my parents. They wouldn't want to think that I'm taking medication. So what do I do? Do I hide that from them? Do I tell them and kind of have to deal with that? So it comes out in other ways. And I think we just have to kind of help them kind of come to terms with, you know, accepting treatment, accepting who they are, and accepting that this isn't all of who they are. It's a component of it and something that's modifiable. And I think that's sort of one way to address that internalized sense.
One of the things that you mentioned earlier is, medical school is an abnormal experience. Even though 17,000 or so students graduate every year from medical school here in the US, it's still an abnormal experience. But there's lots of different checkpoints along the way. Are there trends or stress points that you see that occur at particular times in medical school, whether it be, exams, other transitions going from the classroom to the bedside? Do you see exacerbations of conditions at any of these points? And As educators, as advisors, how can we try and mitigate some of these stress points that students may be experiencing?
Yeah, I mean, some of it's very predictable. I mean, often when people arrive at medical school, everybody has a lot of enthusiasm and they're excited, and that's great. And it isn't until they're a month or two into the academics where they're like, oh, this is harder than I thought, or this is a different kind of learning that I'm used to. So you definitely see more anxiety pop up, or sometimes people's, learning style is exposed. In college, they could do things at their own pace, and now they have to conform to the very rapid pace of learning in the preclinical year. Um, and then as people move on to the clinic, you see more performance anxiety issues, interpersonal issues that maybe were masked or obscured when they were in the classroom. And I think not that there's a magical solution to any of that. I mean, med school is hard and it's maybe hard for good reasons and probably shouldn't be hard for not good reasons. But I think one way to mitigate the impact on people is knowing that there are these predictable stress points, trying to bring back information into the student body about what are the mental health resources. Because I think a lot gets put out during orientation, which is great, but people don't remember a lot from orientation. And knowing when these sort of, pressure points are can be a helpful time for the schools to say, oh, by the way, if you're having trouble, here are the resources. And it may not even be mental health resources. It may be, learning supports, or maybe coaching, that there are various directions people can go. But I think kind of knowing those things can be, because they're so predictable, can be helpful as ways to catch those who are kind of having a hard time.
Um, I, I think we have to recognize that schools have different resources and schools put emphasis in various spaces when it comes to supporting students. I would love to hear what your thoughts are. What should institutions be considering as best practices when it comes to student support, particularly in this area around mental health?
Yeah, no, I mean, I think that the sad reality for all the people doing this kind of mental health work in university settings is there's never enough. There's never enough support. Um, we just have to kind of make do with what we have. I think one way to kind of amplify the reach or the effect that the mental health resources can have are slightly unconventional, meaning it's not just having a therapist and a psychiatrist. I mean, those are important, but also having a robust kind of referral network. So, like at Harvard, we have clinicians who their essentially full-time role is to keep track of local providers, know who they are, know what their specialties are, know what insurance they take, and even know what their availability is. So that if a student needs something that can't be provided by the school's resources, there's a relatively seamless process to connect that student to what they need. Because otherwise, it's kind of a vast ocean out there of trying to find people who are available and take insurance, and that's hard. Even for people in the medical field, it's hard. So having that can really amplify what the school can offer without putting too much of the burden on the students to navigate that when they're already having a hard time. Another are these private companies that contract with the universities that they provide like a telemedicine service. They offer therapy, psychiatry, and it can be really a wonderful resource because they have both expanded hours so they can provide appointments on weekends and evenings, and schools don't always have the flexibility to do that. And also, you can often get a wide array of diverse backgrounds of clinicians, different practices, different ethnicities, religions, gender, and for students when it's very important to them to find somebody that is more like them, they have more options that way, and more than a school might be able to provide. And then again, some of the other things that are important are not, again, conventional healthcare delivery, but knowing what are the other resources in the school, whether it's disability services, mentorship, peer support, just other tiers of support, because not every kind of distress requires professional mental health care. There may be things that are actually better addressed by community resources and can kind of preserve those, formal mental health care for those who have an illness or people who need, a more specialized form of care. But again, we're constantly trying to be creative and look for different ways to provide what students need.
And lastly, before I wrap up with you, I was just wondering what your thoughts are about other opportunities to support our students. How can we sort of, and you started to allude to this with talking about telehealth and other opportunities, but how do we think about where are the needs of our students and how do we sort of empower the students to seek the help? How do we empower advisors and faculty to be engaged in this process to walk along with the students, if that is even appropriate?
Yeah, I mean, there are a number of things. I mean, I think it can be really helpful if there are formal, kind of led by the school, because I think this message has to come from them about ways to demystify the process and outcomes, meaning what happens when a person seeks mental health care? Is that going to go on their sort of permanent record, or is it going to go on their dean's letter? What happens if a student takes a leave of absence, or even, goes to the hospital? Because I think a lot of the hesitation that students have are like, they know that they need support or care, but they're afraid of some unintended consequence that will unfold if they seek it. Um, and I think, again, I think there's really a lot more that could be sort of built out in terms of mentorship and community supports that again, especially because of so much going on in the world and, just what people are struggling with, they need other people, as much as they need mental health support. Um, and I think also and this probably happens to some degree anyway, but whenever students come, to attention where there's been concern about, what are broadly described as professionalism kind of concerns, or even academic concerns, that kind of careful thought is given to, is there something else going on, whether it be stress related, personal related, mental health related, that or even just people who are like, they're first generation, or they didn't come from a background where they had doctors in the family. They just don't know what's expected of them in this culture. And they're trying to navigate that line of, well, I want to be authentic. I want to be myself, but if I'm myself, is that going to be accepted here? And, you know, and it sometimes gets sort of bucketed as, well, they're being unprofessional. Um, and I think there's a lot of room, again, for mentorship and other supports to say, somebody to take them under their wing and say, look, let me tell you what I went through. Let me tell you what would be helpful. It's not you, or something to that effect. Um, so again, I want to have a really, really broad lens of what mental health support can look like.
Thank you. And I think that last question really framed it because, not everyone is a carbon copy of doctors of past, and we're a more diverse special field of medicine, and people are coming in from different backgrounds and experiences. And I think identity plays a big role in that, especially as we try and either decide whether to conform or to sort of stand out and be your true self. One of the things that I think we should talk about at some point, maybe towards the end of this, is imposter syndrome or imposterism, because I think that also plays a role in this discussion that we're having. But want to make sure that we keep time and transition to our next speaker. So, Dr. Opara, I have a couple of questions for you. We've really focused on the medical student experience, but now I want to start to think about the trainee experience. How might their wellness or their mental health be similar, and how might it be different than the experiences of students?
Thank you, Dr. Landry, for that question. Thank you for having me here. I bring greetings from Wayne State University School of Medicine from Detroit. What up, dope? Any Detroiters out there? 313 all day. And the original homelands of the Anishinaabe, the territory of Detroit being originally Anishinaabe, Wawiatanong. So bringing greetings, acknowledging our land and ancestors in this moment. Great question. And I really appreciate that we're having this conversation on this month of April, which is Stress Awareness Month. And as we talk about the mental health of students and trainees, we understand that both populations, at different junctures of their career and learning and education journey, are impacted by stress and stressors, right? That's true across the continuum of learning, education, and professional practice. So from undergrad med ed, med students to graduate medical education to continuing medical education, faculty development, ongoing maintenance of certification, etc. They are stressors and they have very real impact, in lives. But when it comes to trainees, this they certainly have a unique sort of texture, I should say. They're absolutely impacted by similar stressors as and mental health challenges of depression, anxiety, of, like we said, stress and toxic stress and chronic toxic stress that is also layered as medical students. However, there are added layers around now. You have a job.
Mm.
You know, this is a job. And as any one of us who have worked jobs and are working jobs know, workplace environments come inherent with their own stresses. How do you work with your colleagues? I'm navigating hierarchy, navigating politics of the workplace, right? Contending with evaluation. Now, as physicians, with now you got the MD behind your name. So there's this added level of responsibility. I remember sitting with more than my fair share of residents, usually interns, but even more advanced when they have their first death of a patient and sitting with them and navigating that or holding space for those conversations during rounds when we do have a patient die on our team, and sort of helping them navigate this sense of ownership of, my God, was it my fault? Did I do something wrong? What if I did something differently? And that piece there. So this added level of responsibility, this is now my patient, my patient load. Now you got a whole load, you got a panel. It's not those two you were following when you were a student. Now you got 6, 7, 8, 9, depending on the night. You even got a lot more. So that added says, and the whole time you have to remember you gotta pee, you gotta go to the bathroom, and you might even have somebody at home. Right now, you're also navigating because by and large, even though we have shifting trends of who is a student, who is a trainee, now I don't even call anyone traditional, non-traditional now. Like everybody is everything. But I think still the general larger trend is by the resident fellow, the trainee status, folks have families of their own. Again, you still have some medical students who have the same as well, but more by and large, folks have families of their own now, or now, guess who's older, who's growing old with you? Your parents. And so now you'll have dependents. You'll either take care of kids and or your parents, and or for especially for those of us of disenfranchised, those traditionally excluded communities, we are probably taking care of a whole village. Okay, because that little paycheck coming in, okay, 69 cents an hour or whatever we're paying the residents these days, now that becomes for some people the family paycheck. So there's financial also additional pieces that contribute to the stress. So workload, responsibility, longer hours, the truth of it, we have the 80-hour per week boundary. However, that's on average. So that doesn't mean on some days you're not working 329 hours. I made that up. No, hopefully nobody's working that. But it's on average. So you have those days and those moments. And like I said, you're balancing it with all the other things. So trainees absolutely. And don't forget, you got exams too. You got those in service, in training exam, ITEs. And then by the time you're at certain levels of your residency, if you're like, gosh, I think I want to do a fellowship, you're now thinking about research and other ways to make yourself competitive for fellowship spots. So the stressors, the textures of the stressors kind of evolve, and they bring with them often the stresses of being a medical student, but now they evolve and are sort of on a higher level with additional sort of textures and layers that predispose trainees to further mental health harms potentially if guardrails are put in place.
Thank you. I think that was a really sort of broad-reaching answer to the question. It really helps to shape the discussion. One of the areas that you have built your expertise in is the experiences of minoritized and disenfranchised trainees, communities, and so on and so forth. And I think there's something to be said about what it is to be a Black, Latino, LGBT resident in a program that is not diverse. And can you talk about the experience of being a minoritized trainee when it comes to mental health and wellness? Have you seen trends? Have you had conversations with trainees who've come to you and said, "Hey, I feel like I'm the only and I don't relate to, or I'm dealing with these issues and I don't know how to best get support from my department or my institution"?
Unfortunately, I'm a little bit too well versed as I would prefer not to be in exactly that issue. I'm currently dealing with a situation where there's a trainee that is leaving a program for exactly that reason. And you want to layer on that, Dr. Landry, not just the piece that I'm in a PW, I'm a predominantly white institution, but that we're taking care of predominantly of patients who are predominantly look like me. So you got that piece, whereas you're the only or one of few in a predominantly white institution taking care of patients who look like you. And so it's like family, and you're contending with a number of challenges. So unfortunately, I've had to, I'm sort of, being part of that journey for that particular trainee. But there are others that have certainly reached out across the country because there's only so many of us. Again, remember, especially for Black, particularly for Black physicians, we're 5% of the national physician workforce, and 2% being Black women specifically. It's about 1 point something for Black men. So there's not a lot of us. And so being part of national networks, I do get calls and emails and texts and messages on social media regarding this very issue. And so some of the experiences are, being othered right from beginning, being made to feel like they did not qualify for being there, that they took somebody's spot, or somebody else was more deserving and they're not deserving. Evaluations that are unfair, being evaluated on very very uh, vague, unclear standards, being receiving harsher punishment than peers who have done the same, made the same mistake or error. Um, and then there's just sort of like the subtle violence of just not seeing yourself reflected, right, in anything. So you have lectures or slides where, you're not seen. On slide says, the skin tone is not diverse and doesn't reflect, melanin. And again, there's intersectionality there. They also may not reflect different bodies, right? So it might not just be, and that's another key piece when we talk about, the mental health landscape or ecosystem of, frankly, all folks, specifically those, trainees and medical students, and then even more specifically, those who are melanated. And so there's intersectionality. So if you are, a person of color, and also a woman, and also have a disability, and also not born in this country, and also with an accent, and the list goes on, and not Christian, and the list, so those layers also come into play when it comes to these experiences. There, of course, the never-ending microaggressions, which are just really what we call everyday casual racisms and isms that happen, comments that are made not just by colleagues or supervisors, but also by patients and other staff in the healthcare ecosystem. And then again, knowing that these students and trainees, and specifically trainees, are coming from surviving a history. We wear, as James Baldwin says, history is the very present. We carry history with us everywhere. So the current, whoever you're looking at, themselves are a representation of generations of experiences. So they're bringing even into that, that environment, the training environment, the realities of the lived experiences, their own personal lived experience, but the lived experiences of their parents, grandparents, their communities, and understanding that, there's a larger oppressive system that they are surviving every day. And then this just becomes a microcosm of that within the training, learning, and working environment. So these are some ways in which they are often, that these experiences that they have often then impact upon their mental health. And I'll end on this, I'll end on two quick notes, because you mentioned imposterism, and I thought this would be a good place to introduce that thought. So often what I teach, and what I believe, is that especially when it comes to those of us of excluded communities, that this idea of imposter syndrome doesn't really land, right? Because those symptoms, this idea of, oh, am I a fraud? Do I belong? Am I qualified? Those are very real messages that we have gotten and been told. These are not just ideas we kind of percolate and think about, like, oh, I wonder if, no. We have been told that we don't belong, right? We've been told we're not intelligent enough. We've been told we're not qualified enough, despite evidence to the court. The best evidence to the contrary. So these are not sort of like feelings and ideas that we just have. No, these are very real messages internalized. And so I think it's so important to frame that conversation, and especially when you're talking about, our specific subpopulation, because then the response is different. It's not just, well, just believe in yourself and you're really supposed to be here. No, you have to be specifically anti-racist, right? Anti-oppressive in the approach, because these are very real messages that are, delivered by white supremacists, ableist, sexist, patriarchal, etc. Society over generations. So that messaging is so important, because the way it is then addressed by faculty, by leadership, by the mental health professionals or experts within our learning environments is going to have to speak to that reality and not be whatever the general sort of unseasoned, shall I say, response is for the average like person coming in that may be expressing, those belief systems. So I think I'll just end on that note.
That's awesome. And thank you for that. And just in the interest of time, I'm going to try and combine two questions because you alluded to this earlier with the quote unquote 80-hour work week we were talking about, and how much free time or lack thereof trainees may have when it comes to addressing their own personal needs, and really mental health is something that, often gets put on the back burner because there's so much of an expectation for them with all the things that they must accomplish. And so, what have you seen are best practices that residency programs and fellowship programs have put in place to offer opportunities for trainees to feel supported and to get the support that they need when it comes to mental health?
Yeah, great question. So some of the things that either I have seen or that we are still proposing, I think Dr. Abrahamson did a great job of just everything that he shared, but then also speaking about that some of this is also still aspirational. We're still trying to get there. And I love the point that you made, Dr. Landry, around not every system has the same resources. And so there's that diversity to still, contend with. But I think by and large, what many of us can do is, number one, integrate into our training curricula across, vertically, horizontally, and in between, conversations around normalizing mental health, right? And also highlighting and helping people recognize. Because one of the things I've noticed is that sometimes folks don't even realize when they are experiencing symptoms of stress, or this, funky term that I still have a love-hate relationship, which is called burnout. I'm like, okay, burnout is often just an appropriate response to like a system that has lost its damn mind. But I would say that, those symptoms of stress, the stress response, trauma responses, again, and all those, when maybe chronic mental illness has been exacerbated. So you already have depression, or already have anxiety, or already have bipolar disorder, etc. And then it's exacerbated because now you're in these like high stress environments. It's so important that we normalize conversations around that. If one is comfortable to share their own mental health journey, I'm talking about within, having people that have institutional power, so the faculty, the chair, the dean, the chiefs, etc., to create that kind of space. I don't know that we're there yet, but wow, how amazing, where everybody can share. There was a social media trend a couple of years ago. This was 2021, maybe 2021. And it was the whole thing where, and then again, they were predominantly trainees. I love my young people because they just do the damn thing all the time, but they really do represent that courage piece. And so where they showed their medicine, their medication. So they're doing ADHD medications or antidepressants, anxiolytics, antipsychotics, etc. And they put it on their tongue and showed their medicine, and then with a little blurb on, this is my story, I have this and this is what I'm taking. And so this sense of just normalizing, I think, is really important. I think that goes across the whole spectrum of our education and professional development. Normalizing help seeking as well. It's okay to ask for help, and again, you sort of have to back that up, because there is a reason people don't seek help. People don't just seek help because it's sexy. They're not seeking help because there are real repercussions they're afraid of. So how do you ongoingly, as we say, over communicate? In times of crisis, you must over communicate. Over communicate. These are our resources. This is what happens. Be very transparent. This is what happens when you tell this person this is what happens, and this what happens, this what happens, and you're protected. You do not suffer a negative consequence as a result of this, because we need healthy, amazing, wonderful physicians and healthcare professionals in our lives to help us meet, the goals of humanity. So whatever it takes, right? Because again, we know that we lose 300 to 400 physicians, to suicide every year, right? And that the rates are higher, illegally higher, in my opinion, especially when it comes to female, physicians. I believe is 130% higher than the general population, and in men is 40%. So it is incumbent that we set those policies, practices, but also culture and norms in place of normalizing these discussions, normalizing help seeking, being transparent with the process of what happens, but then also thinking about how do we introduce autonomy, right, in the lives of our trainees. So reducing administrative burden, incorporating trainees into every stage of decision making, our leadership committees, etc. We're doing that a lot at Wayne, where we ensure that every sort of decision making bodies include trainees, so that they have a say in what the decisions that impact their lives, right? When it comes to leave, being very clear, having very clear and supported maternity or parental leave and medical leave processes, right? That is very critical. And then again, normalizing work life. I don't think there's anything like balance. I think that's a myth, but integration as well. So those are just a few things that I think I will propose, that some of which I've seen and others which are still yet aspirational.
Awesome. Well, thank you for that. And that was a word. I appreciate you and your energy. I want to turn to you, Dr. Lozano, because I think we've talked about this from a medical student and a trainee perspective, but I think our graduate students and our trainees who are more on the research side often get overlooked, and especially with the turmoil that is happening with our country when it comes to NIH and financial dollars and the concern of grant funding and so on and so forth. I think it's really important to have this conversation with a focus on those individuals, because they have different pressures potentially. And so can you talk to me about what those potential experiences are, and how individuals pursuing a career in research may differ or have similar experiences to our medical students or our trainees? What's the same, what's different when it comes to mental health and wellness?
Yes, thank you so much for that question and for the invitation to be here. And I really appreciate the comments by Dr. Abramson and Dr. Opara. It's just, it's really profound what's going on, and things are really hard. And I think what I was hearing, right, there are a lot of challenges that exist. There's a lot of people doing some great work and doing some of that groundwork and support that's necessary, but also what stood out is the amount of resiliency that exists in the people that are in this field and are doing the work. So these are the medical students, the trainees, the postdocs, right, the early career scientists, and it really takes quite a bit of resilience. And that doesn't mean that it necessarily has to exist inherently within that. By the environment, the support that we're building for people, that we're able to help support them and sort of build it sort of brick by brick to help them get to this stage. Because as you're hearing, right, there's just so many added stressors, and it only gets worse the further along that you move in your career. But the experiences that you're going through are helping to shape and support that and sort of preparing you to be stronger when it comes to, in this case, that we're talking about research. In regard to sort of what are some of the similarities, we've seen a trend over time, and not to say that I've been in this field that long, I'm still relatively early in my career, but there are more people that are, because of the resources that exist early on in undergraduate school and graduate school in regard to mental health services, we're seeing a lot more people entering the research field that may not have entered it before. So people with anxiety disorders or depression or a psychosis spectrum disorder. And so, or even bipolar disorder. So we're seeing a lot of those people in research, and they are creative and they work hard and they're really smart and have some really wonderful ideas. And so we want to continue to support them. However, what hasn't necessarily been built alongside that is additional support or understanding from like faculty who are going to be working with these people. And so, you know, these people tend to be younger, they tend to be sharing about their mental health experiences. And so it's like, well, what do we do? How do we support them? And so depending on sort of what institution you're at, what lab you're in, what department you're in, you know, you may have a little bit more support around that. And so, you know, having a PI or principal investigator or mentor supervisor who's willing to talk about these things and they're willing to work through it with you, right? And sort of establish, you know, a different sort of schedule, different timeline for when things can be completed or accomplished by. I would have to say sort of being in a medical institution that's also affiliated with a hospital, right? You're dealing with, especially at the PI level, right? You're dealing with, well, you know, from a human resources standpoint, there's only so much that we can do and talk about. And so you're put in this position where you want to support your trainee or your PhD student or postdoc, but also you're being told by the hospital system, there's only like so much that you can do, and you kind of need to refer people out. So, you know, some people have hesitated as a result in doing anything, right? And I don't think that's a good response either. And so something that we've done within our group is, you know, we create an open environment where we're talking about things, we're checking in, where you leave, you know, space open to be able to talk about these things without any fear of repercussion sort of internally. And if something does come up, then you have, you know, resources that you can send or refer people to if they're needing further help or support. In regard to what are some of the differences, right? In this case, you know, depending on sort of what you want to do with your research career, whether you want to enter industry or you want to continue in academia, you know, those are two sort of very different paths with, you know, a lot of trainees these days wanting to enter academia, because of what's happening with NIH funding currently, right? And so if you can land an academic job or an industry job, you know, it's better sort of work-life balance, right? Or better sort of, it gives you the ability to better integrate. And so a lot of trainees or people are choosing to go that route. From a pay perspective also, you know, you get paid better as well, and the stress is a bit lower than it would be in an academic setting. You decide you want to run your own research program, you want to run your own lab, you want to have your own staff. You know, it really takes a village to make something like that happen. And, you know, in today's climate where research funding is, you know, tenuous at best in some respects, and in some labs and institutions, right, it just becomes really hard. And so, and then you're not really getting trained on that side of like, how do I manage a bunch of people? How do I manage different projects? What are all the regulatory things that, you know, I'm doing or that need to get done? And so there are some differences. And when you pair that up with what's happening in your life right at that point, you know, at this point, we're talking people are in their late 20s, somewhere in their 30s when this is happening. You know, you have life that's you know, going on in the background, and you have children, or if you're part of a sandwich generation like myself and others here, right, you're taking care of your aged parents as well. And so it just becomes really challenging to manage all of those things. And so finding a really great mentorship team that you can talk about different things, it doesn't always have to be about research, can be really helpful. doing a lot of deep diving within yourself of like, am I where I want to be? What is this what I really want to be doing, and seeking out help if, that can be meaningful in sort of providing that future guidance, that can be helpful. And that help doesn't have to necessarily be a professional provider. It can be, a good friend, like I was saying, a mentor, and those kind of things can be helpful.
I want to lean into this area a little bit more. And when I wrote this question for you, I used the word uncertainty, but I don't think that's the right word. With the current political chaos that is happening around research funding, are you seeing or hearing more concerns from either students or trainees? Look, this is, not to include the fact that institutions are not even bringing in doctoral students because they can't afford them, but for like what are you hearing, and how is this potentially causing stress or just a concern from your trainees when it comes to this very, very important issue of funding?
Yeah, no, there's a lot of concern, from people who are in my lab or in other labs who we're looking to get into PhD programs, for example, and sort of having that funding being cut, from early career people who are thinking about next steps. Just today I was talking to my postdoc who, the next step would be an early career development award, right? Which is sort of sets you up for the next 4 to 5 years of your research career. And wondering like, should I even apply? Is it even worth it? Is it even going to like exist, right? And this is sort of independent of, the DEI work and other things that, the administration has sort of eliminated from funding opportunities. So I think there's a lot of uncertainty, and there's a lot of anxiety and stress around what's going on. And even for ourselves, even if you're trying to stay informed, and you're talking to people at the NIH, it's hard to know what exactly is going on. And oftentimes, or at least what I've heard is, when you talk to an NIH program officer, so they're one of the first people to sort of contact when you're working on a research project. They're like, well, I'm hearing this the same way that you are, which is, hearing it from the news, and from articles that are being published. And so really, it's chaotic. Nobody really knows what's going on until it hits the news. And then you don't know what promises to make or not to make to your staff. They don't know, are they going to be in the position that they're currently in right now? Do they need to find a job? Do they need to move? So it's really, really a stressful time.
So I want to try and, in the interest of time, sort of merge two questions. One is research is very diverse, and I think more so than medicine. I think research also is very international, which again is a little bit different than the practice of medicine. Um, and there may be cultural differences that are happening, and then also within research, although it may be more diverse, it still happens within higher education, which is not diverse. And so I would just love to hear your thoughts about one, that international experience, and especially, and again, I'm not trying to over politicize this, and I know that it's not your background to sort of think about visas and whatnot, but I mean, I think that is something that we need to be talking about, the stressors that are happening from the ability to even to live in the country, but then also to just exist in a system that is complex with labs and departments and grant funding and mentorship. What are your thoughts on how we can best support individuals in a complex environment like the research world is?
Yeah, it's a great question, and something that's sort of very active in our group as well. As you mentioned, a lot of our talent is international, right? And so we have a few international people in my lab on different types of visas. And so the question of like, can I even travel to Canada, for example, and will I be able to return is really a concern. And so we extrapolate that to conferences that may be taking place outside of the United States, where they're wanting to present the important work that they're doing, that even those smaller things become, something that they're really thinking about, should they be doing or not doing. And then, even more importantly, there are some trainees that are here that are international, who are here with families, right? With a partner, with children. And, there is the potential risk of them losing their visa, and they'd have to leave. And so that is obviously would be very devastating. And that's not even thinking about what would happen to the project, right? Like these people were selected because of their skill set and because of their interest, and there aren't that many people that could do that job, right? And so, the impact that it would have on a project is also quite significant. And so this is something that's like very real, something we talk about, or I talk with my staff about on an almost weekly basis, and sort of keeping an open space for discussing those things, for empathizing with them, with what they're going through, and understanding like right now, may not be a time for their highest productivity, right? I guess depending on what your personality style and how you handle these things, but things are going to be really stressful and things may not go as planned right now, and that's okay. We're here to support each other and try to get through it together.
So in the interest of time, I want to try and tackle maybe one or two questions from the audience. There was a question that is in the Q&A that talks about understanding, and I mentioned this about reporting of mental health issues, either at the medical student or the trainee level. And we sort of entered into this discussion, David, and you mentioned about like, will this go into a MSPE letter, or does this come up in my evaluations? And there's all these concerns about like privacy when it comes to mental health, because there may be some implications or maybe not. What are your thoughts about, and this can be open for all, but I want to start with you, David, about sort of best practices about addressing the privacy concerns students may have as we try and navigate the mental health concerns.
Yeah, I mean, a couple of thoughts. I mean, one is schools. I know schools locally who have brought in like uh, specializing lawyers to talk to students and faculty about, well, how do you navigate these questions, like on licensing applications? Because sometimes the wording can really make a big difference. If it says, have you ever been diagnosed, or do you have a condition that impairs your function? The answer may be different depending on how the wording or the question is phrased. And that can help students kind of figure out how can you honestly disclose what they're asking without sharing too much or oversharing. Another, and this often has to be repeated multiple times in any of these forums where mental health resources are discussed with students, to really reinforce that even if the mental health resources are affiliated with the university, they're still HIPAA protected. These are not just free, open conversations that the school can have with the mental health providers. Because I think a lot of students worry, reasonably, but worry that it's all sort of in-house. And hopefully just by continuing to remind people of that, it at least, sort of breaks down some of the mythology about like just the free and open sharing of information that really doesn't happen. There are, I mean, there are still realistic concerns that people may have about what goes in their medical record, but some things we can actually diffuse.
And there is very quickly just a question about sort of best practices, because I think we're all in this space where we want to learn more. And obviously, in our 1 hour session, we're not able to sort of give people all the tools necessary to address this for medical students, for trainees, for graduate students, and for postdocs and junior faculty. Dr. Opara, you started to answer a question, but sort of where do you think people can potentially turn to for best practices and getting more information about how to better support students?
Yeah, I'll answer quickly in the interest of time. I would say, I mean, it's quite a number of things. And Dr. Abramson already sort of alluded to this, which I really love because I don't think we talk about it enough. That yes, absolutely, there should be a robust, if possible, mental health resource base or ecosystem at various medical schools and clinical learning environments. However, that's not always the case. That's not always possible. So we do need to do a better job of building partnerships, right, and collaborative networks within the entire like community where mental health resources might be more abundant or more available. And how do we set up those partnerships with various community groups and organizations and even private practices, etc. That might be practices that may be government run, otherwise nonprofits, etc., where we can provide those resources for our students. But in addition to what I shared in the chat, in the answer portal there, really want to round up this this conversation on mental health with a powerful tool that, my community uses for us to have survived centuries of all kinds of attempts at us not surviving. And that is a tool of joy. And so and one thing I've learned personally is that joy is intentional practice. And it doesn't mean the suppression or the ignoring of grief and of loss and of sorrow and of anger and all those, but it really holds space for all those things while maintaining our holistic overall health, right? Mental, spiritual, physical, emotional, financial, and social health. So really being intentional with how do we inject joy in and create joyful spaces and in a place that allows and celebrates the practice and the expression of joy. I think are sort of revolutionary ways that institutions, groups, organizations, departments, etc., committees can start to think about how we design clinical learning environments for our trainees, students, and otherwise. I talked about in the chat Dr. Sean Jin Wright's model or framework called healing-centered engagement, which is a powerful engagement that is asset-based, not deficit-based. It doesn't ask the question, what's wrong with you, but rather asks what happened to you and what is right with you that we can leverage and, and robustify, if I may, in terms of how we engage with each other to get you to be the best, physician, practitioner, physician scientist, physician researcher, educator, etc., that you are. So I think really situating ourselves in places how we collectively build instruments, tools, frameworks, mechanisms that center joy, rest, play, that center an asset-based approach to engaging with mental health and other forms of health, that centers well-being over necessarily wellness. And there's a difference where well-being is more holistic and includes the entire socio-ecological model, what's going on the micro, meso, and micro levels, but also in addition to, again, what's happening, physically or mentally. And so holding space for all those pieces and having that inform the way we design our student and trainee and learning experiences, I think become really powerful how we move this conversation forward when it comes to the mental health of our students and trainees and faculty as well.
Well, I'm going to end on that note. So I want to say thank you to all of our speakers, to Dr. Abramson, Dr. Lozano, and Dr. Opara. Thank you all for joining us. I want to say thank you to Lynn and Sabrina in the background who helped organize our presentation. And thank you to our audience for joining us over this past hour. Hopefully this conversation will be helpful. As I mentioned, this webinar is recorded and we will post it on our website as soon as we've done our editing and have the closed captions available. But again, thank you to our presenters for joining us, and thank you to the audience for listening. And I hope everyone has a good rest of your afternoon. Take care.